All right, Jessica, we are live.
Welcome to tonight's telephone town hall with Compassion and Choices President Barbara Coombs-Lee and Death with Dignity Advocate Barbara Mancini. If you have a question at any time during the event, please press 0 on the call. On the agenda for tonight's call, we are going to hear from Compassion and Choices President Barbara Coombs-Lee, a nurse, a lawyer, Compassion and Choices President, and Barbara Mancini, who is a Philadelphia nurse who is unjustly prosecuted in her home state of Pennsylvania.
Hi.
Welcome, everyone, to today's telephone town hall with Compassion and Choices President Barbara Coombs-Lee and Death with Dignity Advocate Barbara Mancini. If you have a question at any time during the event, please press 0 on the call. On the agenda for tonight's call, we are going to hear from Compassion and Choices President Barbara Coombs-Lee and Barbara Mancini, who is a Philadelphia nurse who was unjustly prosecuted in her home state of Pennsylvania. Remember to hit 0 throughout the call if you have any questions. I'd now like to introduce Barbara Coombs-Lee.
Thank you, Jessica, and thank you, everyone, for joining. This is a new modality for us. It's a new way of talking with our supporters all across the country. So it's a little bit of a test, and we'd be very interested in how you find the experience. We do this at a pivotal time in our movement, and I think that anyone who has been watching the media, either online media or mainstream media in the last few weeks, has sensed that there's been a bit of a sea change. It started with some very compelling stories. Barbara Mancini is among them, but it has really reached a peak with the storytelling of Brittany Menard and her really heart-wrenching story about her journey, first of all, her fatal illness with a glioblastoma, and then her journey from California to Oregon in order to take advantage of the Death with Dignity movement. What these stories have done is make the problem visible. If I could say over the last 20 years there has been any impediment to our progress in legalizing choice at the end of life and authorizing it, it has been that people are not acutely aware that there is a problem. So Barbara Mancini in particular and Brittany Menard have both made the problem visible. They've made it clear that this is a justice issue, that people do suffer prolonged death, agonized death against their will, and this could be not only our grandparents, but it could be our friend, our neighbor, our sister, our daughter. Anyone whom we love deeply could face these heart-wrenching experiences and difficult decisions and feel as though they don't have the choices that would give them comfort and peace of mind. What these stories have done is given people all across the country an awareness of the problem and the language to talk about the problem. Viewers have watched the Brittany Menard video, I think it's like 8 million times. Barbara Mancini was featured as the lead story in 60 Minutes. The reach of that program is enormous. The challenge now, and I think it's a natural transition, is to turn viewers into activists. That's you. That's the people on this call. Turning you into activists. How to become a person who helps turn the tide, who helps manifest real political change as a result of this moment in history. We'll have some very concrete suggestions for you, and we'll ask you to make some commitments. At the very least, we would ask you to start talking about it. Talk with friends and family. Collect petitions in your neighborhood and at places like senior fairs. One of the most important things you can do is talk to your own physician. Physicians need to hear from their patients that this is an important issue for them, that people want to have a sense of self-determination and control at the end of life. Your doctor needs to know that so that doctors understand that there's momentum, there's political consumer momentum. We'll ask you to get to know your legislators and candidates, electeds of all levels, not only federal and state candidates, but also city and county candidates. Every elected needs to know that these are important issues to you. We're going to ask you to not only be passionate, but start revealing your passion to the people whom you meet and the people whom you touch and the people whom you are able to influence. So that's the purpose of the call today, and I will now turn it over back to Jessica.
Great. Thank you so much, Barbara. Everyone, we need your help to make sure Americans have a say in our health care and end-of-life care. Would you pledge to make a donation right now to Compassion and Choices? Press 1 if you'll pledge to donate $250. Press 2 if you'll pledge to donate $100. Press 3 if you will pledge to donate $50. And press 4 if you pledge to donate another amount. Again, if you have a question that you want to ask Barbara Coombs-Lee or Barbara Mancini, please press 0. I now want to take a chance to introduce Barbara Mancini. Barbara Mancini is a nurse, a wife, and a mother from Philadelphia who was unjustly prosecuted in her home state of Pennsylvania. Barbara is joining our call today to tell her story and what happened to her father. Thanks, Barbara.
Thank you, Jessica. I want everyone to know it's great to be here on this call, and I thank all the Compassion and Choices supporters who are participating. I would like you to know that our family planned carefully, and we thought we had done everything right. My dad had written advance directives, which clearly stated he didn't want any life-prolonging treatment. I was appointed his legal health care proxy, and he enrolled in home hospice care when it was clear that he was terminally ill. So I thought we were prepared. What I didn't foresee was this, that his hospice care would be inadequate, that people outside our family would invalidate his written advance directives, and specifically that was the hospice and the police, and that they would initiate the prosecution of a family caregiver simply because I handed my father his pain medicine. Now, after this year-long ordeal, a judge ultimately dismissed the case. She stated there was no evidence that my father intended to end his life by taking his morphine, nor was there any evidence that I intended to help him die. But the fallout from this prosecution was enormous. I lost almost a year of income, and I incurred over $100,000 in legal fees. Even worse was the emotional turmoil that this inflicted on me and my family, and I cannot forget the physical suffering and the anguish that my father endured at the end of his life because of this. I believe that this would have played out much differently if my father had appropriate hospice care and if aid in dying was legal in Pennsylvania. I don't know if my dad would have utilized aid in dying, but I do know that he would have wanted the choice. Take that back to you, Jessica.
Great. Thank you so much, Barb. But just a reminder to everyone on the call, if you have a question, please press 0. I also wanted everyone to know that we have developed a new Barbara Mancini house party kit, so you can help tell Barbara's story in your community. Press 1 if you would like to receive the house party kit, and we'll follow up with you after the call. Again, a reminder, please press 0 if you have any questions. I will be taking our first call from Corrine in Houston. Corrine, are you on the line?
Do you mean Karen in Houston?
Sorry.
Are you there?
We can hear you, Karen.
Okay. In regard to your suggestion that you let your doctor know about your position on having control of your end-of-life decisions, many of us are prescribed medications that could be used for those purposes, for conditions that we have and have had. My concern would be that if you discuss that with your doctor, will he attempt, or could he attempt, to restrict your access to the medications you have that could be used for end-of-life decisions?
Great.
Should I answer that, Jess?
Yes, I was just going to send it over to you. Barbara Kingsley will answer that question.
Yeah. Yes, I understand your concern. And, of course, it all depends on the kind of relationship you have with your doctor. It's important for doctors to know that these are important issues for their patients. I mean, not only for the individual patient, but, also for physicians as a group to understand that there's a growing awareness and a growing consumer demand. I don't think that it would jeopardize your care or future prescriptions if you just said to your physician, I love life and I feel good and I don't anticipate having a terminal illness in the near future. But if I did and if I were suffering, how do you feel about assisted dying? How do you feel about laws like those in Oregon and Washington and Vermont, where doctors can write life-ending prescriptions for their patients who can take the medication if their suffering becomes unbearable? I think that a question like that, I would hope a question like that would open a dialogue without, sort of creating this backlash of anxiety from your doctor. If your doctor reacts really kind of defensively and judgmentally, if it were me, that would tell me that maybe I had the wrong doctor. And I would want to have a physician when I'm terminally ill with whom my values and my beliefs are compatible. And so I would actually welcome the opportunity to change physicians while I was still relatively healthy and able to do it, and find a physician that I could speak frankly with.
Great. Thank you so much, Barbara. Our next question is from Joan in Indianapolis. Joan, you're on the line. Joan, are you on?
Oh, yes. I thought I'd already asked my question earlier. My comment is that when you go into a hospital, you don't have your own doctor most of the time, at least in my experience and my friend's experience. So telling your doctor what you want an end of life is kind of irrelevant, because when you go in there, you're going to be seen by this doctor and that doctor, and chances are you won't even know who they are. So I'm just wondering, how do you get across the wishes when it's your doctor is, my doctor says, well, I don't, if you're sick, I don't come to the hospital, so that, how do you handle that?
Barbara Kingsley, do you want to handle that call?
Yeah. There's a twofold reason to talk with your own doctor. I mean, one of the reasons is to establish a rapport and an understanding on this very personal, private issue, which may come into play because even attending physicians who aren't primarily caring for you while you're in the hospital, I understand you're usually being cared for by hospitalists, they can play a role and are often consultants, or the hospitalists might call them and seek their advice about your care. So just because they're not caring for you primarily day to day while you're in the hospital doesn't mean that your interaction with them, your relationship with them won't have an influence over your care. So that's one thing, and I think it's just important to open these conversations so that doctors and patients are kind of on the same page, and doctors start to understand where their patients stand. But the other is, quite frankly, I'm asking you to perform not only a personal act, but a political act. And that political act is to raise the consciousness of doctors across the country. Raise the consciousness of doctors that end-of-life choices, control, a sense that people have dominion over their end-of-life experience. That's important to people. And medicine, individual doctors and medicine in the aggregate needs to be attuned to that rising expectation among consumers. So I know that it has a personal impact, and the degree of that personal impact may be greater or lesser. But I'm also looking for, quite frankly, a political impact and a consciousness-raising exercise for the medical profession.
This next question is for Barbara, and it was just emailed over to me. Barbara, how did what happened to you in the last year, how did it affect your family and your life in general?
That's a very good question. It was an absolutely devastating experience, and we are all still trying to kind of get back to a normal life. My hope is that someday we will be able to move past this. We're not there yet. One of the reasons I have chosen to speak out about this issue is I do not want to see another family ever have to endure this kind of trauma like we endured. So we coped as best we could. It was very, very difficult, and I think the most difficult part of this was knowing that my father's death was really a terrible death, and it was needless and tragic. So it's something that I'm going to be dealing with for some time to come.
Thank you so much for sharing that, Barbara. Action and Choices can't work without you. We would love for you to volunteer. Please press 1 if you would like to volunteer, or press 2 to receive the Barbara Mancini House Party Kit. Moving on to our fourth question today. This question is to California. Barbara, are you on the line?
Hello. Which Barbara?
Hi. Barbara from California.
Got so many Barbaras on the line today.
So many Barbaras, or not enough Barbaras.
Yes. Well, we want to hear from Barbara, the questioner, right now.
Yes. Okay. We're having a little difficulty there. Is Linda on the line from?
There's Linda from California. Yes.
Great, Linda. Do you want to ask your question?
Please. Early on, Mrs. Mancini said that she found that the care that her father was receiving from hospice was inadequate. That was the word that you used. Please, would you elaborate on that?
Yes, I'd be happy to. The hospice did not adequately address my father's pain and suffering. And specifically, he was in home hospice care for 2 weeks with no medicine for pain. And I had to initiate a phone call to the hospice to obtain pain medicine for him. So they later used that phone call as evidence in my prosecution, claiming that it showed I was intending to help my father die. My intention was to have my father's pain relieved. So that's something that's that's part of the contract with a hospice, is to provide comfort and relief of symptoms for a dying person. And this hospice failed on that account.
Thank you, Barbara. We now have Fritz in Roswell, Michigan. Fritz, are you on the line?
Okay. I would like to address the question of how successful has the fight been to legalize help in carrying out the wishes of the person who is dying. Is it something? How can a person? How can anybody really find out about getting help on this issue in their own personal cases?
Barbara Coombsley, do you want to take that question?
Sure. Of course, the degree to which aid in dying, which we consider to be the ultimate self-determined choice at the end of life, is authorized and visible and practiced transparently. And it depends very much on where you live. And so in Oregon, in Washington, in Montana, Vermont, and New Mexico, physicians can respond openly, transparently, write prescriptions for life-ending medication for eligible people who are terminally ill, mentally competent residents of the state. Anywhere in the country, people can call upon us, Compassion and Choices, to have very frank conversations, non-judgmental conversations about the challenges that a person might face, the types of care that are open to them, ways to access that care. And we help thousands and thousands of people every year. And sometimes it's just a simple thing like helping a person persuade their doctor that it's time to make the transition from disease-specific care to hospice care. Sometimes it is really helping, supporting, educating, and informing the client and their family about options like stopping eating and drinking, or getting the cardiologist to deactivate an internal cardiac device, or getting palliative support through the discontinuation of some life-sustaining therapy like dialysis. So there are, depending on a person's situation, their diagnosis, their treatment, where they are in their trajectory of their illness, what kinds of treatments they have, and the degree to which those treatments themselves are keeping them kind of in a prolonged dying process. All these things are extremely variable, and our consultants are well-versed in all of them and enter into a pretty intimate and long conversation. The average length of stay, we call it, between the time someone calls our consultation service and the time they die is half a year, 150 days. So these are, as I said, very, very intimate conversations. We hope for the day when aid in dying is authorized and transparent and accessible as a legitimate medical practice that's integrated in end-of-life care in every state. And we work fervently toward that day.
Great. Thank you so much, Barbara. We cannot do this work at Compassion and Choices without you, and we're hearing from a lot of folks on the line who want to volunteer. Please press 1 if you would like to volunteer, or press 2 if you would like to receive the Barbara Mancini House Party Kit. Great, and we'll move on to our next question, which is Sandra in Delray, California. Sandra, are you on?
Okay. Yes, I live in California, and I'm wondering. I know you don't know, but do you have any kind of a guess when we may have euthanasia legalized here, like in Oregon, this next state, up?
Great. Barbara, do you want to answer that question? Barbara Coombsley?
Sure. First, I just want, for the sake of clarity, to make sure that everyone understands the difference between aid in dying and euthanasia. Aid in dying is the practice where a mentally competent and terminally ill adult can ask their doctor for a prescription for medication that they can take. It needs to be self-administered at a time of their choosing if they feel that their dying process is extremely prolonged or difficult. Euthanasia is practiced legally in some countries in Europe. It is not part of the law in Oregon or Washington or Montana, Vermont, New Mexico. Euthanasia involves the administration by some other person of life-ending medication. So that's not part of our advocacy. It's not what we aspire to. We're working for self-administration so that as kind of the final safeguard, it's perfectly clear that control resides with the individual themselves, from the beginning of the process of request to the end of the process that might result in death. We have advocated vigorously in California for aid in dying over the years in various ways. And we were unsuccessful in the California legislature, really by a hair's breadth, and only because of the really vehement, over-the-top opposition. I thought that I was amazed at how strong the opposition was from the California Medical Association. But in 2005, 6, and 7, we were there in the California legislature. We had 2 wonderful bill sponsors, and we were trying to get an Oregon-style aid in dying bill passed in California, and were thwarted by the California Medical Association. The California Conference of Catholic Bishops, of course, was very active as well, but we think that it was the California Medical Association that was really the powerful force that prevented our success. Aid in dying was also on the ballot in California in 1992, and although the campaign did not have very much money, that initiative failed by just a hair's breadth. It was like 49 to 50%. Well, we're in 2014 now, and we've decided that it's time to go back to California with a multi-pronged approach and really build a strong base of support. So we have staffed up in California. We have a robust team of field operatives and communication specialists and researchers, and we are at work in communities across California. We need to, again, make the need and the desire, the passion for end-of-life choice much, much more visible. So in California, like nowhere else, I would say that it's important to participate in this kind of outreach, not only at the state level, but again at the county, at the city level. We need to change the expectations and change the understanding of what people can expect in terms of authority at the end of life. Those efforts are very, very much ongoing in California, and we would encourage you to become involved.
Great. The next question is from Eve Dean Herford in Pennsylvania, or from Arizona. I'm sorry about that.
Yeah.
Eve Dean?
Yes. What I would like to know is, with Barbara Mancini, after her trial, has Pennsylvania been any more lenient in trying to pass the aid in dying bills, or are they still fighting it?
Barbara Mancini, do you answer that question?
Yeah, I'll answer that. I never went to trial. My case was dismissed on a petition of habeas corpus. Basically, I petitioned the judge to dismiss my case, and that's what happened. So it never went to trial. As far as aid in dying in Pennsylvania, we have a state senator by the name of Dalen Leach who has introduced a Death with Dignity bill modeled after Oregon's bill for the past 3 years, and it has always died in committee. It never gets out to a floor vote because the people who control that committee are opposed to it. So he is again introducing that bill again this year, and I just partnered up with him earlier today to try to help some movement occur on this bill, and so we're working on it. We're certainly at the very beginning stages in Pennsylvania. That was a great question. Thank you.
Great, and just a reminder to everyone on the call, if you have a question, please hit 0 and we can try to answer your question. Next call is going to Antonio in Irvington, New Jersey. Antonio, are you on?
Yes, good evening, everyone.
Thanks for joining us.
Hello?
Hi.
Oh, okay, great. Yes, good evening. First of all, I'd like to thank everyone who's been listening out over here into everyone's responses in regards to assisted dying. And I believe that it should be a bill, a Senate bill, and a state bill as well, to initiate to have people to have their choices when they're stricken with all these terminal illnesses, instead of spending their last days months after months and their families having to, assist with the bills and all the bills after the fact, and then for the burial, that is pretty much unfair. I myself is an advocate for it ever since I remember the Kevorkian days, and I thought that it should have been. It should have been the people's choice, because unfortunately, like your story, Ms. Mancini, is unfortunate that when a person is given their choice and this is what they want to do, and the family member gives them the okay, that you have all these backlashes and all this unfortunate judicial and law type of actions taken against you, because it's the people's choice. And I always said, if the government can end the life of someone in prison, then why don't the people have their choice for when they want to end their life, when in regards to terminal illnesses that that only the hospitals and the insurance companies and everyone is making money off of the family members in regards to their health, and unfortunately nothing is getting better. I think that they should have that choice, and that choice as an availability, and that there should be more involvement with government in order to pass a bill regarding these issues, because
Great. Antonio, do you have a question for Barbara Coombsley or Barbara Mancini?
Yes, and it's because the last caller actually answered the question in regards to if she went to trial and how did it ended up in trial. However, she stated she went habeas corpus and pretty much dismissed the case. And my question is, are you planning on revisiting the issue in order to have your day in court and have this problem resolved, and also make more strides in the advocacy for assisted dying?
Well, this is Barbara Mancini. I had my day in court, so it won't go to court again. The way I'm revisiting this is by speaking out publicly about what happened to me. And what I do in the house parties or my speaking events is I give more detail about what happened in my experience. So that is how I'm revisiting it. But my court time is done. It was done when the judge dismissed my case.
Great. Thank you so much, Barbara. Another reminder to please hit 0 if you have a question. The next call is from Sandy in Rome, New York. Sandy, are you on the line?
Yes, this is
Sandy. Can you hear us? Great.
Yes, I can. My question is, considering a family who might be in Barbara's position, is there any service or counseling or advice that would be able to help a patient or family member when the advance directives are not being honored by providers? And I would ask for states like mine that do not have this legal assistance in dying, and also the states that are.
Great. Barbara Coombsley, do you want to handle that call? Sandy's question.
Your question is, what do people do? What are their vulnerabilities in states that do not have death with dignity laws? Is that your question?
No, my question is, if I, for example, found myself in the position you were trying to help your father, is there anybody that could have given me advice on how to deal with these providers that were not honoring my father's wishes?
This is Barbara Coombsley, and I would say again that often our consultation service does this kind of crisis coaching of family members. Now, Barbara Mancini found herself in the moment, and she comported herself very, very well in resisting to the degree that she could the actions of the police, and then protecting herself by getting defense counsel and not making any mistakes during those early hours that then put her in legal jeopardy. But in terms of situations where if you have a little bit of a longer timeline, maybe your loved one is in the ICU, and the question is, well, I know my loved one wouldn't want to have all these tubes. I have an advance directive. It's not being honored. We engage in advocacy, a very personal advocacy, with family members like that all the time, and we'll help give people the words. Sometimes we even write letters that cite the pertinent law about where these decisions rightly reside. And so I would encourage people to use that service. It is absolutely 100% free. We never charge anyone. It's easily accessible through an 800 number. And we like to do it for two reasons. Number one, we are based in service. That's the origins of our organization. That's our job. That's our purpose, is to help people through these difficult decisions. But number two, this is how we learn what is going on at the bedside. This is how we learn about what kinds of advocacy would be effective, what people need, what kinds of policy and legal changes are necessary in order to make the dying experience better for people and their loved ones throughout the country. So I would just, and we have little cards that people can carry in their purse, give to their friends, to encourage people to call and use our consultation services for those kinds of dilemmas.
Thank you, Barbara. A reminder, if you have a question, please 0. And again, Compassion Choices cannot work without you. We would love for you to volunteer. Please press 1 if you would like to volunteer, or press 2 to receive the Barbara Mancini House Party Kit. Next, we have Robin from Freehold, New Jersey. Robin, you're on.
Yes, thank you. I think that legislation along the lines of death with dignity and the choice, the personal choice to use responsibly, is very important. And I think that involving our healthcare professionals in that advocacy for legislation would be very important, because I think their voices would be very strong in terms of supporting such legislation. What kind of opportunities are our health professionals being given to be exposed and informed about choice regarding end of life, death with dignity, and in terms of even presentations and forums to professional organizations, universities, schools of medicine, nursing, social work, psychology, all of that? What sort of efforts are happening?
Great. Barbara Coombsley, do you want to take that question from Robin?
Robin, this has been a real kind of a source of both frustration and enlightenment for us over the last 20 years. You're probably familiar with the how the medical profession has been impacted this, but the wake-up call for the medical profession came in as long ago as 1995, when a study called Support was published in the Journal of the American Medical Association that revealed that most people in America die in moderate to severe pain with their wishes ignored. And that was a hugely embarrassing, shocking study to the medical profession, and it prompted 10 years of concerted effort and enormous spending by the NIH and by private philanthropies that added up to $500 million, that's billion with a B, over the next 10 years, to educate physicians about the need to understand the wishes of their patients, to temper end-of-life care with a real consideration for a balance between the benefits and the burdens of end-of-life care, and to be good palliative care deliverers, make sure that symptoms didn't go unaddressed. The verdict is in because there was a new Institute of Medicine report that just came out about 2 weeks ago that very little progress has been made with this enormous effort with physician education, provider education. The lesson that we have taken from that, and certainly we've been a participant in that, in those efforts as well. We've done a lot of continuing medical education. We've passed laws, like the law of California, that says you cannot maintain your license as a physician unless you receive additional continuing medical education in pain and palliative care. So we have been on the provider education bandwagon ourselves, but we have come to the conclusion that nothing less than a concerted transformational shift in public consciousness is needed. Nothing less than that in order to change consciousness and change the way physicians think about end-of-life care. We think about it kind of like the birthing movement. Birthing today is much different from what it was in the 1950s and the early 1960s. It's much more patient-centered, much more deferential to the needs, the desires of moms to have a more natural human experience that includes their family, etc. Well, the OBGYN community did not come to that because they thought it was a great idea and they were going to transform the birth experiences. They came to that because there was a rising tide of outrage and expectation from women and families saying, we don't like the birthing experience the way it is, all technical and removed and inhuman. We want a different experience, and the medical profession responded by offering that. So we believe firmly that the power must arise, the power for change must arise from the consumer community. We need to create that same alerted consciousness and a new expectation of what people who are approaching the end of life want and need from the medical community. So quite frankly, our attention has shifted from providers in medicine to consumers, to educate them, energize them, and build a force for change among the people, the consumers of America.
Thank you so much, Barbara. Just a reminder to everyone on the call, if you would like to volunteer for Compassion and Choices, and we could not do this work without our volunteers, please press 1 now. Our next question is from John Moser in Aurora, Colorado, for Barbara Mancini. John, are you on the line?
Yes, I am.
Hi, John.
Hello. Okay. My question is for Barbara Mancini, and it's kind of a two-part question. The first part is, does she think that it would be still possible if Pennsylvania did have an aid in dying law on the books, that somebody still could have prosecuted her, either a complaint filed by, say, a healthcare worker that would call the police? Is it still possible that she could have been, prosecuted like she was, or attempted to be prosecuted? And the second part of my question is that even if there is a death with dignity law, I'm from Colorado, which does not have such a law. If you're in a situation kind of like I am, I have a degenerative muscle disorder that's incurable, and eventually I'm doing okay now, but there's no pain, but eventually I'm basically going to become a vegetable. I won't be able to use my legs or my arms or move my head. Even if you have a death with dignity law, is there still a provision if someone figures, well, my quality of life is zero, and I just don't want to live like this anymore, that I could still, have aid in dying help?
Well, I'm going to address the first part of your question. Is it possible, if aid in dying was in Pennsylvania was legal, could a prosecution still occur? And the answer to that is yes, but it would be much less likely. In my particular case, the police captain who arrested me rather smugly informed me that there is no death with dignity in Pennsylvania. Now, if it was legal in Pennsylvania, I certainly am quite sure that my father would have wanted that choice, and he may have obtained the lethal prescription. Whether he would have used it ultimately, I don't know. But the other major issue with my father's case was the inadequate relief of his pain. And that was a huge part of what happened here. And it's my understanding that in the states like Oregon that have had death with dignity legal for a while, that the hospice care has improved since death with dignity was enacted. And they have good relationships with the hospices there. So I think because of that, it would be less likely for any type of prosecution for aiding a suicide to occur in states where death with dignity is legal. The second part of your question, you're talking about your degenerative neuromuscular disease and whether you would be able to partake of aid in dying. I believe that's true as long as you have 2 independent physicians certify that you do indeed have a terminal illness. And what that usually means is you're likely to live less than 6 months. So there's a whole process that you need to go through to make sure that all the safeguards are met and that whoever obtains aid in dying has been properly screened for that. Did that answer your question?
Yeah. Thank you, Barbara. I just want to remind everyone that if they have any questions or want to get involved and they're not on a computer, our 1-800 number is 1-800-247-7421. Again, the number is 1-800-247-7421. We now have Derica Poole from Massachusetts. Are you on the line?
Oh. Hello. I went through a number of problems with my father-in-law when we lived in Connecticut. And he was diagnosed with colon cancer, but with not adequate pain medication. Eventually, with the help of various people who I will not mention, I managed to get together a number of pain medications. We made a deal, my father-in-law and I. The day he could no longer speak and the pain was unendurable, he would raise his arm and ask me to take off his watch. It turned out to be Valentine's Day, unfortunately. But as I said to him when I took his watch off, you will be with your wife in a few hours. But I was doing this in a clandestine way. I had managed to put a number of pain medications into my refrigerator. And I felt, and he also explained, he was very grateful that we kept him at home with no medical intervention. Why is this so difficult to obtain today for people in pain that it's so excruciating?
Barbara Coombs-Lee, do you want to answer that question?
Why is it so difficult? You know, hospice does have a long way to go in many parts of the country, and you know, some hospices are better than others, and some hospices are more adept and feel more comfortable with aggressive pain management. The truth is that sometimes it's very hard to stay ahead of rapidly escalating symptoms, be it pain or shortness of breath or nausea and vomiting at the end of life. And hospices and their medical directors need to be comfortable with doubling doses of both sedatives and opioid analgesics every few hours in order to stay ahead of rapidly escalating symptoms. Sometimes they're just not comfortable with that because they're afraid that the high doses of medication might actually advance the time of death. And it might advance the time of death. And this is where the double effect theory, the doctrine that has sheltered this kind of treatment for many years proves beneficial. And that is that the people delivering care can assure themselves that so long as they intend to relieve the symptoms and they understand that an accelerated death might be an unintended side effect, an unintended consequence, that is ethical and legal in every state. I think that there is a ways to go in pressing that understanding and making sure that that's prevalent among hospices and palliative care physicians and nurses. But it also helps. It helps to be in a state where aid in dying has undergone a public dialogue and been made legal, because that has enabled an awareness that death is not inevitable, that sometimes death is accelerated, the time of death is accelerated, and that is all okay, and it is ethical and moral and legal and compassionate, and what a compassionate society does. I think that awareness is more prevalent and more visible in a state that has undergone the public debate necessary to pass aid in dying legislation. So, in a way, I think that there are secondary effects of aid in dying legislation that also do, as Barbara Mancini said, impact and improve end-of-life care.
Thank you, Barbara. Our final call today is from Joyce in Honolulu, Hawaii. Joyce, are you on the line? Hello. Hi, Joyce.
We have compassion and choice in aid in dying in Honolulu, Hawaii, and it is legalized under what is called a POLST, P-O-L-S-T. However, the doctors and hospitals will not honor it, and the insurance companies won't, because of fear of being sued. So how do patients, and how do we, even after the laws are on the books in states like Hawaii, how do we motivate them to get over this mountain of fear?
Barbara Coombsley, do you want to answer that question?
Yes. We have seen cases where EMTs and nurses in nursing homes have ignored a POLST, and ERs have ignored a POLST. A POLST is, as you noted, it is a medical order. It turns the wishes that are memorialized in an advance directive into a medical order, and the purpose, it can be very beneficial, because then if someone is dying at home or suffers some catastrophe at home, if the POLST is there, which is an order that is effective not only for physicians and nurses in a hospital, but across all medical settings, usually family members can feel quite confident in calling 911 and knowing that the EMTs will come, but will not do a full code and will not subject their loved ones to a lot of traumatic, injurious treatment, but will be able to just deliver comfort care. Well, often that works. It's worked very, very well in Oregon and other states where it is widely accepted. But we well understand that there can be some resistance. We have brought some cases, and we're involved in a case in Florida right now that actually litigates against the people who impose this unwanted medical treatment, essentially as a battery, as unwanted treatment, unwarranted touching in violation of the POLST. So, kind of if there's fear on the side of honoring the POLST, we want to create some balancing fear on the other side of not honoring the POLST, so that in the end it will win out that you do the right thing and you honor the POLST. Another tact that we think will be very successful, and we're working on this with a huge federal campaign called the Campaign to End Unwanted Medical Treatment. And that is to prevail upon the payers, the Medicare payers, the Centers for Medicare and Medicaid Services, to withhold payment for treatments that were delivered in violation of a POLST, a MOST, or an advance directive. And I think that would be a huge disincentive if physicians and EMTs knew that this was just not reimbursable care. It shouldn't happen. It has been ordered not to happen. If people provide that, despite the clear orders to the contrary, well, there's no reason that they should have an incentive to do so with the promise of federal dollars paying them to do it. So I think removing that reimbursement, saying it's just not eligible to be paid for. We're not going to be we're not going to be honoring Medicare claims for resuscitative efforts that should not have happened. That I think will be a very powerful thing if we can get it done, and we are actively engaged in trying to do so.
Thanks, Barbara. We need your help to make sure all Americans have a say in their health care and end-of-life care. Would you pledge to make a donation right now to Compassion and Choices to keep up all of this great work that Barbara Mancini and Barbara Coombsley have talked about today? Press 1 if you will pledge to donate $250. Press 2 if you pledge to donate $100. Press 3 if you will pledge to donate $50. And press 4 if you pledge to donate another amount. Well, we're done with questions right now. We are going to go to some closing remarks from Barbara Coombsley and Barbara Mancini. Barbara Mancini, do you want to start?
Sure. I just wanted to thank all the people who participated in this conference today. I appreciate everyone who has supported and donated. We have this common goal to achieve end-of-life choice for everyone in the United States. And I will be speaking about my experience in select cities throughout the United States. I welcome the opportunity to share more of my story for anyone who cares to listen. So thank you.
I would just echo that, and I would also thank you, Barbara Mancini. You withstood an ordeal for a year, and you have become such a valuable, persuasive, a compelling advocate. Your words ring out and really bring to consciousness the harm, the fear, the difficulties that people encounter because we don't have clear, authorized, legitimate aid in dying accessible everywhere in the country. People like Barbara Mancini, people like Brittany Menard, our ranks are growing. We will succeed, and we're grateful for those of you on the call who aim to help us do it. Thank you so much.
Thank you again, both Barbara Mancini and Barbara Coombsley, and everyone for joining us and our volunteers that were picking up the calls. If you have any questions, please feel free to give us a call at 1-800-247-7421. Again, the number is 1-800-247-7421.